Radhika is an assistant professor at the Weill Cornell Medicine, a professor at Weill Cornell Medicine in emergency medicine at the Weill Cornell Center for Global Health. Oh my God. Okay. So Radhika has, actually, she's a double doctor. She has a medical degree and is a board certified emergency physician, and also is an anthropologist. And I think has such an interesting background. Radhika is doing a couple of different R01 implementation science studies in different contexts, looking at traditional healers as implementers, and is doing just very interesting work. I met Radhika, who was part of the High IRI program, which I'm going to talk a little bit about tomorrow. She was one of the speakers during my first year and spoke about context and ethnography. And I remember just being completely enraptured. And so when we were planning this program, we immediately thought to invite her to have us join us and hopefully get more than 20 minutes, which is what she had the last time. And even that really was quite engaging. So we're looking forward to learning more today. So thank you, Radhika, for being here.
Thank you, guys. It's a pleasure to be here. You are gonna get some Post-its. I would like everybody to take 5 Post-its. You can take 6 if you want, if you're gonna write a lot. Everybody get out a pen or pencil or crayon or marker. So I cannot possibly talk for 60 minutes. You do not want that to happen. So this will be participatory. And I also wanted to say that this is a very conceptual talk. This is not necessarily a pragmatic talk. If you have pragmatic questions, I'm very happy to answer them. But I want you to think kind of conceptually about context. So I'm not going to give you instructions per se, but I hope I'm going to make you think about things. All right. Ooh. Touch the screen to begin. Use the keyboard. It's not, but that might be my fault. Spacebar should be. Oh, spacebar. That's the one thing I didn't hit. I'm so sorry. This is a brief roadmap of what we're going to talk about. I know you've already had a lot of presentations and discussion about qualitative methods, so I'm going to go pretty quickly there, depending on what feedback I get from you. And then we'll talk about ethnography. We'll talk about qualitative and ethnographic methods. And in the setting of an equitable implementation science, we'll talk about ethnography to assess context and implementation science. I'll give you an example of the work we're doing in rural Uganda, and I'll talk very briefly about equity among ethnographic researchers. So let's get started. This is a show of hands. You don't have to write anything. How many people in this room feel comfortable reading and engaging with qualitative research in general? That's most people. Excellent. Next question then, since many of you are sort of working in that space or comfortable with that space, write down on your Post-it, what are some weaknesses that you perceive of qualitative methods? It doesn't have to be a lot, or if maybe there are many weaknesses and you want to write a lot, that's fine. Once you've written down what you want to share, pass them up. I'm not going to put anyone on the spot, but I will share some of the responses out loud if that's okay, so we can kind of get the sense of what the temperature is in the room. What are the weaknesses of qualitative methods? You have weaknesses written down. Pass your stuff up to me. I will summarize. There are a lot of weaknesses. What are some weaknesses of qualitative methods? Who's being graded? Pass them over, pass them down. And got more. Great, excellent. Thank you, thank you. You guys can use it yourself. Here you go. Thank you. All right. We're red on red. I don't think I'll try my best. Oh, awesome. Thank so much. Okay, let's see. Some weaknesses, time constraints, that's an excellent one. Biases, researcher bias, difficult to analyze often, that's perfect. We heard this again, resource restraints, reliability, variability, time intensive. Again, we are all aware that time is a big part of investing in qualitative methods. Generalizability is limited. That's a good one. I hear that all the time. There were questions about rigor. That's a good point too. It feels like a lot of complexities are involved in qualitative research, and sometimes it's difficult to apply and understand. Rigor, again, coming up again, is this a rigorous way? In implementation science, qualitative is very thin. It's almost all interviews, focus groups, content analysis. Thank you. I'm about to talk about that. Differences in approaches, there's no one right way. That's great. Replicability, validity. These are not the goal. I love that. That's not the goal. But if we're talking about this coming from a quant perspective, people are often like, well, how come I can't replicate this? Can't replicate it because you didn't do it, right? Representativeness can be unclear. Specific to participants, time consuming, excellent. You need a team, so there's a lot of investment. Subjective, yes, absolutely. Political power to impact structural change is limited. I love that answer. Let's talk about that. It doesn't test a hypothesis. No, it does not. And it can't really, but sometimes that's a weakness if you don't know, right? Maybe not generalizable. Unclear how you can draw conclusions, lengthy, time consuming, slower, time consuming, generalizability. Okay, excellent. So I feel like we got thematic saturation. I'm going to go over this very quickly. Qualitative research is different than quantitative research. The process is iterative. We are constantly engaged with analysis and then reframing how we do collection. Qualitative rigor is different. This has already come up. The goal of qualitative rigor is that we are generating specific data, not generalizable data, and that we want our explanation to be high quality, right? We want the explanation to be tightly reasoned, and we want the insight to be original. And there are multiple approaches to analysis there. Here are some ways of collecting qualitative data. Anything that's non-numeric, that describes events, experiences, personal stories. Ideally, when we're engaging in collecting qualitative data, we want perspectives, individual lived experiences, right? Feelings, opinions, behaviors, interactions. Here are some ways, again, non-exhaustive ways that we collect qualitative data, but I'm going to focus today on ethnography. So what is ethnography? This idea is that we're combining fieldwork, research design, methods of inquiry to produce historically, politically, and personally situated accounts. So ethnography is the idea of learning through experience. Does anyone have a background in social science here? Anthropology, social scientists, great, perfect, love it. Welcome. You guys can correct me if you disagree. Ethnography is a controversial term, right? Because social scientists love to argue about words. So we, of course, are like, that's not ethnography, is this, and it's also this. So whatever we want to say, let's use a working definition. A working definition is that this is a research method. This is how anthropologists try to understand the world. By exploring a phenomenon from the point of view of its participants. So this is an inherently phenomenological approach to knowledge. We are trying to learn from people and with people, not about them alone. Right, so I think a lot of what we do when we get into research, community participatory research, community engaged research, we are trying to learn about people. The point of ethnography is to learn with them and from them. There are actually a lot of instances in which ethnography is kind of peeping into implementation science. So here's one reference if you want to look through it. Here's another reference more recently published, just showing you that different kinds of qualitative and anthropological approaches are popping into implementation science. This graph is very hard to read, so I apologize, but basically showing you that Document review is that big line on the top, right? So document review, site visits and kind of in-person experiences are at the bottom, right? So when we're talking about ethnography, we're talking about doing and seeing and being part of something. That's still a pretty uncommon strategy. So how can this sort of be a part of an equitable implementation science? Why do we need this? Well, I think all of you know qualitative data allow us to discover and document a lot of different important things that are really central to implementation science: context, implementing environment, implementation processes, and relationships. And I think importantly, the relationship between what we think is going to happen and what actually happened. Sometimes we need qualitative data to understand that, right? And I think this cartoon is sort of silly, but it gives you an idea of like, if you're only measuring things quantitatively, you won't understand, right? You need words, you need experiences, you need opinions to actually contextualize all of the things that we think as implementation scientists are important. And in implementation science, I'm sure you've heard this already this week and in your life, right? Context as king. Context is the most critical part of what we do in implementation. And different theories, models, and frameworks have different ways of assessing context. But in fact, all these TMFs are usually just enumerating aspects of context. They're not telling you how those things are related. They're not telling you how people are positioned within that context. They're not telling you about experiences in context. And that's something that we have to think about and covering. And those thorough evaluations depend on qualitative data. So thinking about equity in research, your next writing assignment, don't write too much. What does this picture mean to you? Write some ideas about what does this picture mean? How do you interpret this picture? This is probably not the first time you've seen it. You've seen something like it. What does that picture mean? You can write it. You can write it. You can say it. If anyone has something written, I'll take it. I opted for writing because sometimes people don't want to talk. You guys are talkers. Responses. What does this picture mean? Maybe it doesn't mean anything. What do you think it means? What does this picture mean, if anything? What does this picture mean? You have individual inequities and structural inequities, right? There are some things that are happening outside the individual, and there are some things that are happening at the level of the individual. You need context to understand all of the picture. Excellent. That's exactly what we're talking about. This is a big picture. Individually oriented preventions are not accounting for barriers. That's exactly what that arrow is, right? Individual level approaches will fail to address underlying problems. Sometimes we overlook actual drivers of health as scientists. Individual approaches for macro level changes. Single action interventions are not enough for a solution that is equitable. And sometimes we may be holding one person accountable for change. We need political solutions to drivers of health. Sisyphus, yes, that's the picture. Sisyphus, excellent. I was waiting for someone to say that. Social determinants of health influence health outcomes. Excellent. Individual behavioral change is a heavy lift because of context. This is a heavy lift, right? That's a big ass stone. More energy is needed to achieve outcomes when there are a lot of barriers. Yes. This person may have a lack of privilege. Yes. This is a picture about syndemics. Absolutely. Social determinants of health impact health. Social determinants impact health and outcomes. Social determinants affect the way we experience health or lack thereof. Preventive action is difficult at combating health hazards when policy and social determinants are greater in intensity. Well, this is great. Very nicely summarized. Structural challenges to living for Black, Indigenous, and people of color folks. Not using a preventative approach to treat the individual. This fails to address contextual and environmental factors. Structural issues cannot be solved by individual preventative actions. So I completely agree. When we're talking about equity research, it means that we are required to interrogate structures that have perpetuated inequities in health in populations. And we are required and tasked to design solutions to achieve optimal health for all people. While quantitative measures can describe, document, measure health outcomes, qualitative and ethnographic data can do more. We can shed light on individual lived experiences among minoritized populations. We can share and document and illuminate experiences of discrimination, oppression that are shared across communities. We can identify social and structural drivers in inequity. And importantly, how are these drivers of inequity reinforced? Through practice. That is what we can begin to approximate through ethnographic work. One thing I want to say out loud, qualitative methods are not inherently equitable. It is not about the method. Equity is a characteristic of the data and the science and not the method. So just because someone's doing qualitative work doesn't make them doing equity work, right? The perspective of the research is embedded on how we apply these methods. We need to have critical assumptions about positionality. And of course, in implementation science, there are boatloads of people who prefer to focus on individual action. I personally do not think you are getting anywhere towards health equity by focusing on individual action. That's what this picture is telling me, right? That we need to interrogate these ramps. So that's where I think our contribution towards equity can begin. I want to talk about culture as part of health equity. Of course, again, for the anthropologists in the room, I apologize. Let's define culture quick and dirty. Okay, again, this is a contested concept. Culture, for all intents and purposes here, shared norms, values, experiences that collectively shape a group's attitudes, beliefs, and behavior, right? Culture, shared between people. Not everyone has the same experiences, of course, but we all agree because we have grown up in a society, we've been socialized a certain way, we all believe certain things have meanings and values. That's culture. This model is called the Penn 3 model. This was developed ages ago in the 80s, so excuse me. But this model, I think, is very useful. It was initially developed as a way of thinking about HIV interventions in African countries. The idea behind the Penn 3 model is that culture frames health. And these are sort of the decomposed aspects of culture that have been theorized. So the idea here is that the influence of culture on individual health is to recognize that the forest is more important than the individual tree. And what that means is that individuals are important, but what is perhaps more important, impactful, actionable is the forest, is culture. And if we think about identifying cultural strengths, we can potentially frame health solutions rather than focusing on barriers. And I think this is one of the greatest problems in public health, global health, is we come in as scientists and we say barriers, 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 there's barriers, there's so many barriers, right? This isn't working, nobody knows how to do this, there's no fidelity. That is perhaps not the most productive way to frame an intervention or a solution, right? Let's think about leveraging strengths And the Penn 3 model says, look at the culture, figure out what's working well, and use those forces to develop something that is going to probably work. And I'm going to give you an example. Let's talk about ethnography to assess context. Okay, and again, I really apologize for you guys, the social scientists in the room. You just have to bear with me. How can we assess cultural context? How? How am I supposed to do that? Right, these cartoons give you a little bit of an idea. A little bit, just a small hint. Let's start here. Write down on your paper, what is the difference between a twitch of my eye and a wink? Physiologically, there is no difference, right? That's a twitch. That's a wink. What's the difference? How would you explain the difference? Oh, okay, you guys just want to talk, that's fine. I love it. Intentionality. What did you write? Intention. Audience perception. Symbolic meaning. What does a twitch mean? Stress. I just didn't sleep enough last night. Great. But physiologically, it's the same. It's an object, it's an action. What makes it a wink? There you go. There's meaning. There's a message that's conveyed, right? There's intention. There's symbolism. So both are rapidly contracting eye movements, but a wink can be a lot of things. A conspiratorial sign. It's deliberate. It's public. It has meaning. What we are doing is called thick description. Okay? And again, I apologize for those people who have already sat through or read the interpretation of cultures. I'm going to talk a little bit more about that. By using qualitative and ethnographic methods, we are trying to gain a window into meaning, into cultural context by doing interpretation, right? We learn from speaking to people, listening, observing people who have lived experiences within a context that we are interested in studying. That is a way of moving towards thick description. The methodology is participant observation, all right? Participant observation is longitudinal, immersive, and is a way of us capturing, gaining insight towards the lived experiences with people within a predefined population. We both participate in and observe the phenomena that we're interested in. We create in-depth assessments of culture, and this is the foundation of ethnography. So ethnography is a very old anthropological tradition, and we'll talk a little bit more about this later, but the oldest sort of classic ethnographies are like the Margaret Mead, the Malinowski, these books where they would like go live on an island in the 1800s and like, you know, be like, oh, these people do this and they trade boats. And, you know, it's like a full on kind of unpacking of the time when there were like undiscovered cultures, right? That doesn't exist anymore. There are modern ethnographies that are much more interesting and nimble and kind of more sort of complicated and invoke kind of positionality. But the idea of ethnography is that you go, you live with those people, you observe them, and you try to understand how they make meaning. So how can that help us in implementation science? If you don't want to write, that's fine. How can ethnography help us then? I'm telling you, this is great, super interesting, super fun potentially. You learn a lot about lived experiences. How can this help us with implementation science research? Oh, you're going emic edic right now?
I am sorry.
Emic edic is this idea that there's an external perspective and then there's an internal perspective, and that those two things may not have the same definition, right? But the idea is that maybe you can approach the emic, right? The internal, the insiders. What else? Why do we care about that in implementation science? Why do we care what people's insiders are experiencing?
Humility in terms of like not knowing and learning from the population. them being the experts of their lived experiences
Right.
rather than, it's one of the risks is you gotta know. And that environment, ethnographic is like, it's like being not knowing neighborhood.
Yes, and they can maybe come up with solutions as you showed this morning, right?
I was just gonna say that they give you the inside scoop, right? Because when you are embedded in, like, they'll talk to you as if, like, you're a researcher. They're gonna talk to you as if, like, you're their friend. And then when you are analyzing the data, you know whether or not your findings really are consistent, even before you do the member checking, right? Which is what you should do.
Yeah.
Right? You'll know whether or not your findings are probably gonna be on par with what it is people's experiences really are.
Sounds like what you're talking about too is trust.
Yes.
Because maybe after a while they forget,
Oh, they do.
you're not from here.
If you're doing it good, they
Yeah,
do.
that's right. You keep showing up, right? You keep showing up. I'm starting to trust you. Exactly.
I feel like ethnographic data captures nuances
Mhm.
that aren't otherwise captured by like quantitative data. And so especially with implementation science, where we're trying to implement within diverse settings and across diverse contexts, those nuances become really important.
That's so true, right? And we just talked this morning about, you think you make it beautiful for your grant and you're like, this is the strategy and it will work through this mechanism. And then you go do it and you're like, well, this fucking failed. And then but it's the little things, right? It's the wink. It's the little things that you would not have been able to interpret or understand or give meaning to if you didn't embed yourself in some way into the culture of how people understand, live through process. And part of what I love about implementation science is that we love process. Right? That's what we do. We understand process, we unpack process, and we try to sort of use that to guide us towards solutions. Wonderful. This is my way of explaining how ethnography can help us. Because what you know is where you are, right? And what we're trying to do with ethnography is to understand the whole elephant. But everyone is going to have a different idea of what it is. Right? And so we want to be able to take a step back and say, okay, this is an elephant. It's not just a spear. It's not a snake. It's not a tree. Not that everyone is wrong, because their experiences are shaped by what they have exposure to, but that we can get a bigger picture. Right? So ethnography, I think, can give us information on positionality, which we know is very important, our own positionality, but also the positionalities, right? And the different areas that people live, where they inhabit space within that culture, representation, intersectionality. Semiotics is really the goal of studying culture, being able to understand linked and interdependent meanings. And what we do is we're harmonizing these multiple perspectives to paint a picture. And that's an interpretive picture, right? That's the description. So this is my forest. Epistemology tells us how we know something about context. And I would just, again, I'm not going to be too disruptive, but I do like to be disruptive. Consider ethnography as a guiding method for gaining knowledge about context. Maybe this is how we can get to context, because context, in my opinion, in implementation science is a huge black box. Right, we're like, oh, there's inner setting, and then there's outer setting, and then there's the dynamics, and right, but nobody is explaining it to us. Well, what matters? Whose power matters? Whose voice matters? Right, and ethnography can help us get to that. So I think ethnography is a great way to guide program implementation. I'm going to talk to you about my stuff now as an example, not necessarily the way to do it, but just a way of operationalizing some of these crazy things that I'm talking about. Okay, I don't think I need to tell you this, but for those of you who don't work in the space, the African continent is the sort of epicenter of HIV infection globally. 75% of all people living with HIV live in an African country. What I also think is important and different when we're talking about HIV in African countries is that people don't live in urban settings as much as they live in villages. And that's actually quite different than most global settings. So in the US, we already know, like, very few people live in rural settings, and globally it's less than half, but most people live in rural settings in African countries. And where I work in Uganda, it's actually 3/4 of people, right? And that brings its own context. So this map shows you in orange, these are people living more than 2 hours from a hospital, right? That's a lot of people. That's most of the map. Yellow means these are actually sparsely inhabited areas, and yes, they're also 2 hours, more than 2 hours from a hospital. Green is basically the urban centers, right? People are within 2 hours from a hospital. Why does this matter? This matters because people in rural communities are being left behind. There is massive inequity when it comes to the HIV continuum of care in rural African countries. This is an example from Uganda. The dotted line on the top is 95, 95, 95. So you can see we're not there. But the rural populations are very far, right? Starting from testing all the way through the continuum. So this is not great. So let's think about context. What's the context of rural Uganda in my case? A lot of people talk about barriers, problems, so many problems. So what are the problems in rural Uganda? The problems have been succinctly described as traditional healers, bottlenecks, right? Delaying care. They're taking people away from clinics. This is a really nice study from rural Mozambique that shows you pretty definitively that if you visit more healers, your time to getting diagnosed with HIV exponentially increases. So if you went to one healer when you started to be symptomatic from your HIV infection, it might delay you by like 90 days. If you go to 2 healers, we're talking about 180 days. If you go to 3 healers, we're going into years. Delayed diagnosis, that's bad. This is a problem. These people are problems. However, are we sure? There's a lot of qualitative data out there saying that traditional healers are actually good guys. They're trying to help. They're positioned in their communities. They see a lot of people, and maybe they're not the problem. So taking this into account, I thought, we really don't understand this. We don't understand this context. We understand quantitatively this context, right? I showed you numbers. You guys were like, yeah, those numbers are bad, right? Quantitatively, we understand this context. Qualitatively, we don't understand this context. These are all traditional healers. I like to show this when I start using the word traditional healers because everybody has an idea. And usually it's crazy, right? Witch doctors and like face paint and like, you know, feather dresses or whatever, like crazy stuff. These are normal looking people, aunts, uncles, neighbors. They live all over. Every village has one, with not more than one. They work in a variety of practices. So the woman in the upper right works basically like at a clinic, right? The guy in the middle, that's his home, and he has a structure there in his home to see patients. The lower right is actually a school. All those people are traditional healers, and they're there to help learn how to pick medicinal herbs. So these people are everywhere. So we thought, let's go hang out with some traditional healers in Uganda. Let's talk to them. Let's not just talk to them. Let's talk to their patients. Let's not just talk to their patients. Let's talk to the clinic people. Let's talk to everybody involved in the HIV continuum of care, right? Let's just talk to people. Let's get a sense. Let's ask them. Let's ask them specifically about HIV testing because we know that's the entry into the continuum. So we were thinking, okay, how do we make the first bar go up? So we asked people, do you care about HIV testing? Why would you go? Why wouldn't you go? We kind of, again, we hung around and tried to get a sense of what was going on. So a lot of people were telling us, again, the Sisyphus pushing the rock, they live far away from where HIV testing is accessible, right? The roads are bad, it's far, it costs me money. Why would I spend money on transportation when we're hungry? Like, that's crazy. My family needs food. Why am I going to take a taxi to go get an HIV test? When you get there, it's time consuming, you wasting time. I'd rather go make money. And there's stigma. And someone from the clinic said, when someone comes for testing, God forbid they see someone, they know, and then they're going to leave. So it's not an inviting, confidential experience. And of course, with any screening test, low perceived need, right? I feel fine. Why would I get a test? That's not an HIV specific problem, but it is low perceived need for testing. And we wondered about this as we started talking to people. How do we leverage a strength? How do we leverage what we are seeing as a strength? Traditional healers are ubiquitous. Traditional healers are trustworthy. Traditional healers are preferred first line of healthcare. How do we leverage that strength to improve this question of testing? So we started asking people, again, this is a theoretical question. If we offered HIV testing at this traditional healer practice, would you take it? What would that be like? What do you think would happen? And people said, oh, that would be great. First guy says, I can do two things at the same time. If I'm here anyway, why wouldn't I take a test? Right? Great. That's efficiency. And interestingly, people said, actually, this would be better because it's confidential. Because traditional healers see people for all sorts of stuff, right? Family strife, bad luck, tummy aches, headaches. And you say, well, they don't know why I'm here. So I can get an HIV test. It's not stigmatizing for me to be here. And then obviously we kind of expected this last category, but it was kind of interesting to hear people unpack that, right? They don't believe in Western medicine. They'd rather go to a healer than waste time at the health facility. So it seems more like culturally appropriate to be doing it there. And this client at the end said they're common people, like their patients. And they'd much rather talk to them than a doctor. And so this is a comment about social distance. Right? People say, I would prefer to actually receive this from someone where there isn't this massive social distance. I feel more comfortable. So we came up with this schematic and we thought on the orange side, we're showing a road, right? The road to testing as it is long. There's lots of turns and checkpoints and kind of barriers where you can fall off the road. Maybe we could streamline that because we have a confidential, convenient, and culturally appropriate venue. So we thought, okay, let's do this. So we did a cluster randomized trial of this intervention that was completely generated by the people in this area. And we said, okay, well, people think this will work, so let's see, right? That's the best we can do. So we designed a cluster randomized trial. We did the work in Mbarara and Rampara districts, which is southwestern Uganda. You could see the prevalence is a little bit higher than most of the rest of the country. Can HIV self-tests provided by traditional healers improve uptake of testing? That's our simple research question. We did a parallel arm unblinded cluster randomized trial. Primary outcome was uptake of HIV testing. The intervention arm was traditional healers offering self-testing. The control arm was referral, right? So more than nothing, right? We said, okay, well, we'll refer you. We'll give you information on where you can get a test. We'll give you 90 days to go, right? So those were our primary outcomes. And of course, secondary outcomes related to new diagnoses and linkage to care. Here's some photos from our training session. So every single person there is a traditional healer, except for this woman in the striped sweater, who's a nurse from the clinic. And they actually know how to read. We didn't really, again, we were tailoring all of this to like whatever they could bring to the table. And many of them did know how to read. So we were like, great, here's some instructions. They're reading the HIV oral swab kits. The feedback we got from them was, yeah, we would love to provide HIV testing, but I'm afraid of blood. I don't want to be using the needles. So we said, oh, that's easy. There's oral swabs. Totally validated for layperson use, right? Perfect. The other thing we heard was, and again, this is not unique to Uganda, but, oh, people felt uncomfortable doing their own swabs. Maybe I don't do it, I'm not do it right. I want someone to do it who knows how to do it. So we taught the healers how to do it, to actually administer it, right? Supervised self-testing. So this was our training. And this is not a sophisticated histogram, because I'm not a quant person. This is a histogram of our primary outcome. On the right is our intervention. On the left is our control. The black bar is patients that were enrolled at each healer site. The red bar is the number of people who got an HIV test. So they told us this was going to work. I wasn't surprised. The people who reviewed this paper did not like my results. Because you can't have 100% uptake. I don't know if you knew that. when you do anything in science, it can't be 100%. My statistician was like, I don't know how to deal with this because statistics is for error. And there's no, like, this is 100, right? So we got 100% uptake. In the control arm, again, we gave them 90 days. So we gave them 90 days to get a test and only 23% got a test in 90 days.
Can you, just because you commented on it, can you say a little bit more about like when people agreed to be in the study? That was before they would know which condition.
No, it was a cluster randomized trial, so we didn't do an individually randomized trial. So when they came to the healer was going to either offer them a test or offer them referral. So they didn't know that when they got consented.
Okay.
Does that
That's
make
like
sense?
if they already consented to be in the study before they
Knew what they were gonna
like,
get.
I could get a test today.
Correct.
Like, yeah.
Correct.
Okay, and they still all said yes.
Yes.
I'm just trying to underscore how.
Oh, thank you. Thank you very much. Thank you.
Like, there's not a trick where like they had already said yes to get tested before.
No,
they tried to consent.
I mean, I think we did a lot of training on this because I wanted everybody to understand, like, they can say no, and I want you to still enroll them. Right. I want you to enroll people even if they say no. We had 2 people who declined to enroll. So this was my K-23, and my K mentor was like, oh, thank God you had 2 people who said no. And I was like, okay, because otherwise it just looks like you totally made this up. And I was like, I mean, 2 people said no because they couldn't stay for the consenting process. But other than that, everybody said yes.
How close was the consenting process to the testing?
Because this was a completely new trial, the consenting process had to happen before the test. So as soon as they were consented, they could get the test, but in some cases they had to wait like an hour for the team member to come to the site. So that's why some people were like, no, I gotta go.
And the control condition?
Same thing. Before they could get the referral, they had to get consented. So they didn't know what they were gonna get until they consented, if that makes sense.
Maybe you'll get to this, but what's the culture, the dynamic of like the authority of traditional healers, right? Do
Yeah.
people feel like they can say no to getting an HIV test from a traditional healer?
Yeah, I know, it's a good question. I think the dynamic is that they feel like peers. It's a very kind of even, while people go there on purpose because they believe they could benefit from their treatment, they don't necessarily feel like the healer is going to persuade them. They actually talk more about advice, right? If they advise me, I should do it. I mean, I might show some of those, but we have a lot of interviews from people that said, I didn't really think this was important, but then my healer provided me with this education and then I realized I should do it. Right? So it's almost like they could say no, but then they felt like, well, if he told me, then maybe it is important, if that makes sense. So, I mean, it's not perfect. I'm going to tell you a little bit about what we're doing now. But you can see, this is kind of a slam dunk, right? Healer facilitated HIV testing increased uptake over 4-fold. So that's good. We're very happy about that. And importantly, we didn't just get people to take tests, but we actually found new cases, right? Because it's like, oh yeah, like get everyone to do the screening test, but nobody tests positive or nobody is newly diagnosed. So we also find interestingly the 23% who got tested at the clinic, we could not detect any new diagnoses because I think that rate is just too low for the prevalence in the community. So 4% of all tests were positive. Here's our 10 newly diagnosed as part of the trial. We had 2 lost to follow-ups, but 70% did link to care within 30 days of being diagnosed, which is great. This, I think, helps to summarize what we saw. And I think you're going to see there's a lot of parallels to the prelim data, right? The ethnographically driven data. But we're highlighting the experiences, but also the desires of people who are marginalized from formal HIV services. And using those data, we developed a program to effectively respond to their health needs because it incorporated an existing, culturally embedded, and highly desirable context for HIV care. Again, I think the point being we are leveraging strengths rather than trying to overcome barriers, right? I can't make the clinics closer. I can't make people not live in poverty. That's the long game, right? But to solve a problem, you need to leverage a strength in a context that is feasible, right? So let me talk very briefly about the work that we're doing now. Again, just to show you how rural these areas are, all those structures you see are traditional healers that we're working with. And their catchment areas like the mountains, right? So like the people who live in the mountains go to them. It's a beautiful, beautiful part of the country. So we have expanded this based on the fact that we were so good at increasing HIV testing. We said, why don't we train traditional healers to be involved in the entire continuum of care, right? They can help with adherence. They can help with linkage. They can help with retention. So that's the current R01. We're in year 2 right now. Our research questions are here. Can traditional healers support their clients living with HIV to enter and remain in care? Will traditional healers delivered support improve viral suppression? That's our primary outcome. And how do we tailor this program for generalizability and scalability? Those are all traditional healers. We have 44 in this study, so it's much, much bigger than the last study. That bottom picture is not traditional healers because I'm in it, but that's my study team, and the man in the middle in the yellow is a traditional healer. Finally, I don't know how long I've been talking. Sorry, I don't believe in watches, so someone can tell me if I'm close to time. Let me talk very briefly about equity among ethnographic researchers. Okay, so let's be very clear that I am not fantasizing about anthropology being like the best discipline, right? We are very kind of clear that anthropology and ethnography are born from racist colonial traditions. They are still dominated by white scholars. These are, there's a couple of papers here that have described anthropology as white public spaces. Academics from minoritized groups in social science disciplines face a lot of micro, but also macro aggressions. And I think this speaks a little bit to the presentation we heard this morning. A lot of times, folks who are doing community engaged and qualitative researchers, if you're coming from your own minoritized community, those studies, those projects are reduced to activism, right? They're reduced to community service, right? They are not respected as academic work. So like, just be clear that there are problems with equity among researchers as well that we should, of course, think about in our own positionality reflections. Okay, last. Do you guys want to write this or do you want to say it? What did you learn? Maybe nothing. If you learned nothing, don't say it. What did you learn today?
I don't know that for me it was a learning per se, but just reinforcement of how important it is for us to lean into and understand strengths. Everyone has a strength, even if they are racialized, minoritized, oppressed.
Yeah.
Everyone has something to bring, and the more we as researchers can be humble and ask what, and look for that, I think the better the outcomes will be for them as well as for us.
Yeah, I love it. I love that. Thank you. Anything else?
Anthropologists are fun too.
I don't know that we're fun. I don't know. Very internal struggles. Tortured anthropologists. Yeah, great. Right, there's going to be strengths in your context, and I really think we need to frame our brains differently in implementation science because we're so used to barriers, right? There are barriers, like we're not going to pretend there's no barriers, but let's frame ourselves in a way of like identifying the strengths and maybe lifting those things up. One thing that I have, thought about this work and how kind of exciting it is because people showed this to us, right? The people in these communities showed us this system. And when you talk to clinicians, they hate this, right? So no, there aren't a lot of people who don't like what I'm doing for various reasons. But what I'll say is the people who hate this the most are African doctors. So African doctors, I have been yelled at by so many African doctors because they think it's not responsible, right? You are empowering this group of people. They don't conform to our social system. They don't conform to our health system. They don't do what I say. So a lot of doctors are very used to being at the top of these pyramids. And medicine in many ways is very paternalistic. Right? And so this idea of empowering people who are on the fringes, on the margins of the health system is very dangerous to them. And I think what has been so fun about the work we're doing is I'm bringing them into the same room. You know, and I have all these interviews with them and they're like, okay, so I'm going to be honest, like I definitely thought what we were doing was crap. And now I'm seeing that it's working. Right? Because that person left our clinic 2 years ago and you brought them back. And that's something they couldn't do. But we are in the community, right? And again, it's not me, it's the team, it's the community, it's empowering them to do work that they actually want to do. And so that is very exciting, I think, to me. And I also, again, like to be disruptive. So it's fun when people are like very challenged by, you know, like the hegemony of Western medicine is not the answer all the time. Nor is it for us all here either, right? So this is not unique to Uganda, but like, I think we need to just think about what are people doing anyway? And again, and I say this a lot in a lot of my talks, I think one of the failures of global health is that we spend so much money investing in systems, clinics, hospitals, and then we stand at these very expensive hospitals that are being funded by billions of dollars from multilateral organizations, and we go, why aren't people coming here? How come they're not coming here fast enough? And we're not thinking about where do they actually want to go? Maybe they don't want to go to you, right? Go where they're already going. And again, I didn't have to build, you know, a mobile clinic. I didn't have to like build a structure or anything. These are people that are already choosing. And so a lot of it is tapping into that desire. Any other things that you learned? Yeah.
I have a question, if that's okay.
Yeah.
I'm wondering about your own positionality and how you were able to develop trust within that respective community, because you did say like they wanted
Yeah.
to show you, they wanted to give you that access to see the system that, you know.
That they're using, that they have, that exists, right?
So I'm wondering like how you brought, you know, all this baggage across borders and was
Yeah.
able to develop that trust.
I think that's a great question. So I've been working in that part of Uganda for about 15 years. And it's not me. Like I go to some of these places and I meet people and everyone is very nice, but I don't speak the language and I'm obviously not Ugandan. Right. And so a lot of it is my team. And we have an excellent team that I've been working again with for about 15 years. Part of it is showing up over and over and over and over. So traditional healers are very used to being used for the Ministry of Health. When we have a Ministry of Health thing and they want you to come to a training, fine. They're very used to like a one and done situation. So we started back in the 2010s for initial preliminary qualitative work. Oh, you want to talk to us? Okay. You want to talk to our clients or whatever. But we kept coming back and we kept going to their neighbors and we kept asking them, who else should we talk to? And we kept asking them and asking them. And I think it's that idea of like, we actually are investing in this. And I think that makes them, I mean, we're trying to publish a paper about this, but like the external validation of what they're doing is very meaningful. And I think that's something that I got a good handle on very recently. Is like, why do they even bother to work with us? Because like, I mean, they get a little bit of a like compensation for their time, but like not a lot. I think it's that they feel like I'm in a room with a doctor and like we're working together on something. And that is very meaningful for them. And I think it's part of that is, and with any community engaged work, you have to keep showing up. And you're not always going to agree. And I've met plenty of healers who don't want anything to do with us, and that's fine. Right? And, you know, and again, it's not me. It's the team on the ground. Let me just summarize what I hope maybe you learned or remembered or thought about. Ethnographic and qualitative methods can provide critical data to guide equitable implementation science. Ethnographic research can facilitate thick descriptions, which is a detailed assessment of context. Consider using ethnography as an epistemology that could facilitate generalizing about context. Through thick description, we can perhaps try to abstract to general principles or theories or explanations about how things work. Qualitative methods are not inherently equitable. Equity is a characteristic of data and science, not a method. And I showed you a case example of how ethnographic data guided the development of a successful intervention to improve equity in HIV testing in rural Uganda. I have so many people that I work with who are wonderful. And those are real starfish. If you ever go to Zanzibar, they have these massive starfish and they don't look real, but they are real. So if you ever get a chance. And I'm open to any other questions as well. And this is my contact info. Yeah.
Gender, like, was part of it. But that's gender, age group.
Does that affect?
Hesitancy for uptake.
You know, that's an interesting question because there are traditional healers that are men. There are traditional healers that are women. I didn't get into too much of this, but there are specialties. So men tend to be in one group and women tend to be other kinds of healers. It's interesting because I was expecting that maybe we would have this like same gender closeness, but we really don't. And I saw a lot of female traditional healers helping male patients get into care. And I saw a lot of male traditional healers help female patients get into care. And then same gender also. So I wish I could be more smart about this, but I don't know that much has come out despite me wanting there to be something in how we like align these pairs. But I will say that some male traditional healers are what are called bone setters. So they deal with orthopedic injuries and almost all their clients are men. Right. And so there tends to be more of like a male to male kind of relationship. But one of the things we've also expected through this work is that potentially we could find more men with HIV because as you guys know, like programmatically, people have struggled to get men engaged in HIV care. And so we have theorized that this pathway, that this strategy could be one way to do it. And we have seen, again, our continuum of care study is only a year old, but we are seeing a lot of men come in through that door. It's very interesting. So I always thought, again, I learn a lot just from doing the work. I always thought traditional healers would be like old, wise people, right? Like old people who have been through it or whatever. Some of our most successful healers in this current trial are like 25. I have this 25-year-old spiritual healer. He is crushing enrollment. He's the top enroller in this study so far. He's gotten 18 people into care in a year, which is a lot because these people are hard to find. So again, he's like very charismatic. Again, like it's very interesting. And this is a kind of a sub-analysis we're going to do at the end, but it's like, what are the characteristics that make someone better at this? People go into traditional healing for a lot of reasons. Usually it's passed down from families. But in order to do it well, you have to have a little of that charisma. You have to be good at listening. You have to be, they have all the natural kind of like peer counselor traits. But yeah, like there's some really old ladies that like, have been delivering babies for 50 years and like they're doing the project. And then I got this like 25-year-old who's just like finding all these people. So it's interesting. I don't have that granularity yet, but I'm constantly surprised. So these are all questions that we're like thinking about as well. Thank you.
Really fascinating. I came into this with some notions about disabilities and challenged it, so I appreciate that.
Sure.
I'm wondering though, I think I do some work in South Africa and Zimbabwe, and handing out a test or facilitating testing is really different in my mind to facilitating sort of continued engagement in care.
Yeah.
And I wonder about like if all of these traditional healers are at a distance from sort of the places where care might be traditionally delivered, how your study is going to create sort of continuation and systematic sort of continued interaction
Right.
between the healers and the sort of
Health system,
Western
yeah.
providers, it seems like a much harder and much more interesting
Yeah.
task for the R01 to kind of
Yeah,
create that.
so it's because it's a longitudinal thing.
Right,
Right.
right, exactly. So how do you
Well, I think the premise was that these people are going to healers longitudinally anyway. We had some data to show that people go to health systems, maybe the formal health sector, 2 times a year, and they're going to healers almost once a month. So we kind of came up with that idea of like, if you're in HIV care, again, presuming you're stable, because of course you're not stable, then you need to go more. But the fact is that they're already going to these healers. And we try to liberalize the like support delivery. So we were like, we want you to meet in person because we think in-person counseling is probably the best, kind of social support. But in some cases, people were like, well, but we're traveling. And I was like, then just call them on the phone or go to their house or, whatever. They all live in these communities that are close. So again, and this is how the strategies are being adapted, right? And that's what we're trying to study. How are they making their own adaptations to the sort of training protocol we gave them, which was like, what are some factors that help ART adherence? Why should people disclose their serostatus? How do we provide counseling on mental health? Like those are the kind of nuggets we gave them. And we were like, operationalize this in whatever way it makes sense to you. So part of it is that, part of it is like, they're already going there, but yeah, they get, and this may be the case in Zimbabwe too, once you're an established patient, you do get like clinic transportation as part of your regular visits. So that wasn't the big barrier. But it's mostly just having someone there who they can kind of call whenever they need help. And that's longitudinal. So we'll see. We're gonna do our first year 12-month viral loads in September.
really
So
interesting?
I'm like,
It's fascinating.
we'll see. I feel like it's working, but that's the sort of qualitative person in me. I'm like, this seems good, but I don't know. I don't know if the biology is going to be at odds with that, but we'll see.
Let's do it.
So we'll see, but thank you. Other questions?
We were talking at about IRB, stuff like that. How, what complexities and with like this work that you're doing and like IRB approval, stuff like that? Like in I'm doing a study where community implementers are the interventionists, and they had to be like, they had to do like an alliance agreement with that organization.
Oh,
and each
interesting.
of them had to do like an IRB training for that, which fortunately they were able to do, but I'm curious.
Yeah, I mean, I think if there was some sort of a national organization of traditional healers, you could have done something like that, but there is not. They are like loosely organized individual providers. So there's really no way to do like a reliance agreement. We did a lot of training on confidentiality, protection of, rights, and how do you sort of respect rights to refusal, et cetera, stuff like that for the healers. Part of what we're doing is that's part of our fidelity evaluations, right? And we do 6-month, we call them refresher courses. So every 6 months we bring them all back and we go over everything again, but also we help them talk to each other. So they get to say like, oh, this is, we have our 25-year-old super enroller, and everyone like listens to him talk about how he's finding all these people. And then we talk to the people who have struggled. And we say, well, how can we help you find the people, right? Or what are some challenges you're finding with counseling, for example? So we do have some like surveillance built into it. But I will say, I already told you this at lunch, but like the IRB didn't know what I was doing, right? They were like super confused. And they were like, you can't enroll healthcare providers and then study the healthcare providers. That's not like how research works. Right? And I was like, well, actually it does. Implementation research doesn't work like that. So it's been a little tricky, but I think the Ugandan IRB, they like understand, because they're like, this is a completely informal sector. And so whatever work you're doing with them is more than has been done. And so we just have to like see it and take it slowly and kind of go from there. But the US IRB was very confused.
So in the vein of IRBs being confused about ethnographic research, right?
Yeah.
I'm wondering if you'd be willing to talk a little bit about any challenges challenges you've had with reviewers understanding some of your proposals. So personally, I sometimes get reviewers who do not understand anthropological work at all.
Oh, sure.
Right, and so I'm wondering if you can talk a little bit about this, because it's never useful just to have this internal monologue when you're like, oh, there's more than one way to do science, right? Like, and then like
Yeah.
being all cranky and trying to fix everything.
Are
but, like,
you talking about NIH in particular, or,
yes,
yeah?
yes, NIH.
So I find NIH grant writing to be a very slippery slope, right? You have to know your audience. And yes, there are not gonna be like card-carrying anthropologists in your study section, right? Like Peepaw and Hibby, like do not have anthropologists on it. You will have PhDs, right? You may have sociologists, right? You may have some people who like know the social science literature. But I always feel like I try to write for doctors, and sorry, there are doctors in the room. I'm a doctor, so I feel like I can talk about doctors. Doctors are not good writers. Like, you don't really learn how to like write science in medical school. You're like learning doctor things, right? Like the clotting cascade or whatever. Like, doctors aren't good writers. And therefore, if you make something really complicated, they're also not going to understand it. So I really try to write for doctors, because I think the more simple you can make something, the better it is for everybody. Right? So if you're going to invoke a social theory, which you should, like I've been talking with some of my colleagues about like structuration theory, right? Like, isn't that a great, like, it doesn't Giddens have the answer for everything, right? We've like the way that people kind of influence structures, but also agency is constrained by structures at the same time. You know, how do we like develop interventions around that tension between structure and agency? You can use that as your overarching theory of change or whatever, why would this work? But you have to make it digestible. I mean, even when I think about writing implementation science into my grants, I try to make it digestible to someone who doesn't know about implementation science. Because I don't think you can assume that everyone is going to be as like sophisticated with terminology as you are. So I always get my friends to read my grants who don't know about implementation science, and if they don't understand what I'm doing, I'm revising it. Right, so even if I'm describing a mechanism, a strategy, you know, this is my overarching TMF, like they have to understand it. So I really think that the way that I think about the world is not the way I write about it. Does that make sense? The way that I talk to you about this, I'm not putting that in a grant, because they're gonna be like, what? Epistemology for what? Right? The description, why? Right? I think you need to, yeah, that's my advice as a grant writer and a grant reviewer is like, if you're writing for me, awesome, make it kind of spicy, but like, you're not writing for me. You're writing for someone who's reading 8 R01s and like probably doesn't know that much about your own particular thing. Yeah. It's a great question. Well, thank you guys. Appreciate your time and your attention. Thank you so much. Thank you.
Okay, so we have a 15-minute break. We'll see you all at 2:30. Don't forget about the Post-its in the back.